Good morning to all the participants. We ask you all participants to keep mute of audio while speaking. If you have any doubt with uploading of PPT, you can send the mentioned mail and WhatsApp number so that we can play it behalf of you. Today I am here to represent the Nursing and Diabetes Conference web on behalf of Mounsha and Aishnavi. I am especially thankful to Mounsha and Aishnavi, who amid her heavy burdens, duties, and responsibilities to make this event happen today. I would also like to thank participants, especially those of you who are coming from miles journey, for joining us and sharing your valuable experience and ideas. With a good number of participants, I'm sure that the conference will be a memorable, highly educational, and not to be missed event. Yesterday, we have successfully completed the first day in person. Today, we are going to start virtual presentation. The webinar aims to provide an aid for people to share, analyze, and result all features of webinar on Second International Conference on Diabetes and Nursing Education. It is a honor for me to welcome all the participants in this webinar on Second International Conference on Nursing Education and Diabetes. Myself, Maheshwari, representing Intelli Global Conferences, welcome all distinguished guests, dear doctor, scientists, educators, colleagues, friends, and ladies and gentlemen. Today, we are going to cover the following tracks related to the nursing and diabetes. Thank you all. I repeat again, make sure to introduce yourself at the beginning. Ensure that you have a clean, work appropriate background. Look into the camera when talking instead of looking at yourself. Be aware of your audio and video settings. Now, I would like to request Diane True, University of Wyoming, United States of America, to start with speaker presentation on the value of collaboration in advancing diabetes, self-management education, building programs for recognizing and sustainability.
Morning, and thank you, everyone. You just had to get me unmuted so we could do this. It's, as always, it's my pleasure, and I have my slides, and I will bring them up now. So it's always my pleasure to be at a global meeting. I'm sorry that I wasn't able to be there in person. The university has kind of put a kibosh on everybody's travel for the moment, but it's always my pleasure to share. And as most of us are working in the field of diabetes for these many years, I've had the privilege with my clinical partners and I to celebrate 25 years together working in rural Wyoming, which is a pretty amazing feat for anyone these days, but especially in a state that is extremely large but has only the second smallest population in all of the US. So we truly practice frontier medicine except for 3 cities in our entire state. So in preparing for this conference and for this presentation, I did take a peek at all the different projects and things that were going on around the world. In my partners with the IDF, I appreciate the fact that we all practice in incredibly different programs. While many of the countries have very large, metropolitan areas, most of our medicine is practiced in truly rural environments and very small clinical and hospital settings. So Wyoming discovered very, very early that there aren't many of us, and it was very, very important to figure out how we could all work together, how we could all stay educated together so that we could provide, those key pieces of education and care that really bring not only quality improvement to the sites, but the best patient outcomes that we can bring for our patients, and the professional satisfaction and growth and development for our staff. So when we were looking at the objectives for this, diabetes self-management education is a critical component. I know we're all here because we all believe that providing patients best practice and best evidence-based medicine is critically important. But there were key pieces that help patients empower those positive outcomes and hopefully reduce the chronic conditions that come with long-term diabetes. So the world, we're not alone anymore. About 11.1%. So, about 11% of the world now, when I did this presentation or a similar presentation 2 years ago, only about 11% of the world had diabetes or confirmed diabetes. That has now risen to about 14%. And we all know that there's another 40 to 50% of folks who are unaware about their prediabetes. And that's totally risen over the last several years. And it's expected to rise even more. So being here together is really critical. We're seeing the highest rates, in the Middle East and of course, North Africa and Oceania. And those rates are alarming because there are also areas of the world who have fewer resources and fewer centers of health, and larger just populations of folks. And they're mostly rural, which is why I was glad to be here to talk, because I'm used to working in rural environment. In America, that relates to about 589 million people, or about 1 in every 9 individuals living in America. And in rural sites, we're finding that rate is even raising more. And we're discovering in a collaborative partnership, which is why we're here, that it's because they don't have advantages of the education and that they don't have the resources for fresh fruits and vegetables. They don't have as many options for healthy commodities, and they don't have access to big centers of excellence in diabetes. And so that access has really changed how we have learned to practice. So over the last 25 years of working in medicine in a state that is almost as large as Alaska, but has fewer people, it becomes important to have diabetes, self-management education. And we've done it in collaborative partnerships. We first developed networks of educators and providers who came together first for learning. So we were all on the same page at what are the standards of practice? What should we be doing for our patient? What skills need so that we can give them so that we can deliver those self-management skills to our patients. We've overcome through telehealth and doing Zoom, how to deliver to those areas that have both the socioeconomic challenges, which is transportation area. I live in the Rocky Mountains, which are beautiful. And for those of you who might be, used to the Alps and Switzerland and places like that, much of our region, especially in the winter, looks like snow-covered mountains. And that makes transportation difficult in the winter. So telehealth has become a way to deliver to those rural areas where otherwise transportation and education may not be possible. So I really looked at what it has taken for our centers for diabetes and our recognized sites, because in America, you all have to be recognized by the Center for Medicare for Excellence. What the planning has taken to bring educators and providers together as a one voice, so that as people do travel, and they're more transparent now, and you can travel in more places, that they're all receiving that evidence-based best practice medicine, and it's consistent, because our rural population end up at the big medical centers in many cases, unfortunately, in emergent situations for care. So there's a lot of planning that went on. We developed a network who met regularly for the first 5 years. First it was monthly, and now it's still quarterly, and then annually for education. And now it's actually semi-annually for education. There's many, many hours of preparation that it took to put a network together, because we need to recognize and be recognized in order to be part of the American diabetes standards, or their Association for Diabetes Care and Education. That's both part of my job, is to take the sites who had educators and physicians who wanted to be champions for that education and bring them together, provide them the resources and tools to become recognized sites and centers of excellence. And we built them grassroots from the bottom up. And now we have a network that covers the entire state. And that's brought sustainability. It's brought cohesiveness. It's brought that networking that absolutely has become essential. So it's a journey. Like any other program, it's a journey. The next piece we did is decide who needs to be part of that journey. So not only were our providers, our clinicians, our specialists, our endocrinologists part of that support team at that professional level, but we looked for nursing, for our dietitians, our pharmacists, especially because medications are very complicated and costly. And then we looked for our mental health and social services folks, because diabetes can bring that burden of any comorbidity and any chronic disease. Most sites took 6 months. Oops, I love the typo. 2 to 6 months in just preparation and making sure that our sites had that clinical provider champion that really saw that patients were directed for education. Recognition takes paperwork, and that's where I got the privilege to sit in almost every one of the sites and personally help them become a recognized site. And the interdisciplinary team became critical. I think all of us would agree that empowering individuals to take care of themselves overcomes a lot, because it's not easy to tell a patient and a family, in many cases, that they have one more thing in their life that they have to manage, and yet do it in a manner that will hopefully reduce the complications because they've learned those self-management skills. And we all have seen the benefits that when you have fewer complications, quality of life is better. And I believe that because of the work that the global work is done, the International Diabetes Federation, our American Diabetes Association, and our clinical partners, the evidence-based best practice that is patient-centered then became the key elements. Sustaining is tough. Many of you live with socialized medicine, and that's not what it is in America. There are a lot of private pays. There are a lot of private facilities. We have Medicare, we have Medicaid, which are government-based insurance, but many people have private insurance. But unfortunately, even in America, there's a lot of individuals and families who are either underinsured or have no insurance at all. So that was part of the issue, is how do you still bring care to those who really need it? And so we relied on our state partners. They help us collect the data. They help us look at our outcome measures so that we know that we're providing the best care that we can to our patients, and that we can document it so that we're able to deliver in the most economical manner that we can. And so we have fostered a culture that talks to each other. And in many cases, it's absolute a collaborative partnership. And it's shared accountability. And for us, it's across the whole state. We all meet in person at least once a year. We meet quarterly to talk about challenges. And if there are folks who are having issues or problems, we spend a lot of time providing technical support so that they can do the best they can in a rural and, in many cases, frontier environment When your little town's only got 600 people in it, it provides different challenges. And how do we overcome those? We do orientation. This year, it's been almost once a quarter. We've had a new team come on board. And there's all that. What is diabetes? And are we all talking the same standards of care? And I've been privileged to be part of the team for our certification programs who provide not only the ongoing education, but that initial education, because we bill for a lot of our services, even our financial folks and our financial officers need to understand they've all been doing the work, but how do you bill for it, or how do you cover for it, or if there are grant funds to help support new programs. And fortunately, through the university, we have been able to provide that infrastructure that allows us to build, the quality improvement pieces and help them with the tracking pieces. And in many cases, it's even providing the software for them to track those outcome measures. As I said, 65% of our country in Wyoming is rural. And somebody laughed when I said, what do you mean rural? And I said, well, many of the towns are 25 to 50 miles apart. And back in the old Wild West, they were stagecoach stops. And they are still, in many cases, considered places to stop and get gas and to rest. And they are still 25 to 50 miles apart. And in some cases, the big centers are 300 miles and support a large rural population. Many of our folks are ranchers. They grow the beef, the grains. In Wyoming, it's sugar beets and barley. And so they don't want to leave town. They don't want to leave their animals to come into town except to do their banking and buy groceries and maybe gas for their farm and ranch equipment. So it's a real challenge to have that environment, which is critical to people's livelihoods and to the state, because they provide a lot of food and a lot of resources for the state, to still receive the education. So telehealth has become a key. And many of our sites, in fact, now all of our rural sites that provide diabetes education can connect with one another, just like we're connecting today. So, right now I am sitting in Montana, and we'll be back in Wyoming, later tomorrow. And so we're still able to provide the care. The other, obvious challenges is allowing folks their work schedule, their childcare schedules, and in Wyoming in the winter, it is absolutely the weather. What we have seen is it's how we practice. We absolutely practice what's important for the patient. Those patient-centered goals are sometimes hard for us as educators and clinicians to understand that it might just be in February being on your property because that's when your animals are having their babies. It might be, how do you leverage those community and social resources when there are gaps in those social determinants of health, to ensuring that people have enough food and good shelter and the support that they need, to just take care of their daily lives. And that's why we have worked so hard in collaborative partnerships. And many of our sites who are in larger populations, for example, Cody, Wyoming might have 12,000 people. We provide telehealth services to the small clinics. So at home, or at least closer to home, folks can come in to a telehealth network hub and dial into us if they don't have internet, because not everybody has internet. Not everybody has Starlink available to them when you're in the middle of the mountains, and still receive not just diabetes education, but actually consultation and services. And we have trained the staff at those small clinics how important, patients getting labs when they need them, how important it is to have, their height, their weight, their blood pressure. And they can fax us, the blood sugars, and we can review the labs or any of those other clinical pieces that we need, hopefully the day before. And many of our folks who are computer savvy from home can upload them to us so that we can review them, perhaps before their visits. I think that what we have done and what the global network has done to bring us all together is as much critically important as our seeing our patients. It reaffirms, the commitment to that quality, to the sustainability, and to how do we deliver the best care possible. And our teams of caregivers, our care teams, have integrated now to also include our cardiovascular medicine components, because as we all know, you can't separate those cohorts anymore. Hypertension, especially in Wyoming, is the number one chronic disease behind cancer and diabetes. And so we've taken the last 2 years to make certain that the cardiovascular education is a key component also to that education, so people understand how important it is to not only maintain your blood pressure to prevent your heart attacks and your strokes, but also to preserve, our kidney function and just general wellness. And I think, recognition of programs gave us a healthier beginning, and when we have completed that as a collaborative partnership, whether it's all in person at a center or it's through remote education, we have changed the outcomes for many patients. I had the privilege just to complete an audit for one of our rural sites. They've completed 8 years as a standalone site, providing services to about a 300-mile radius through telehealth to the small communities. And we looked at their outcome data. Their average A1C was right around 9% prior to education. And at the end of the first 6 months, and we just did an annual review, the average A1C was coming right close to 7, which we know is goal. And people were losing weight. They were achieving their own personal goals, those patient-centered goals, and they were having healthier behaviors. They were eating better, moving more, and in many cases, even their blood pressure medicines were reduced because they understood the importance of how those positive behaviors were helping their health. There are so many references for looking at rural healthcare. Last year, CDC published a big paper on how to support rural America, how to support smaller populations of folks who will never be able to support their own diabetes centers or won't have access immediately, like across town. And I've had the privilege for the last 25 years to be part of that task force to help small communities and the larger communities connect. And my clinical partners and I don't too often get to spend 25 years helping a state and our partner states move forward to have better health outcomes and healthier communities. I don't think there's anything more rewarding to have that and to have healthy visits with patients because they've achieved their goals, or they're moving forward. And we get to see visits that really talk about how their families are doing and how they are doing. And I've had the privilege to have had one of the first sites and centers in the state. And I still look at, 25 years later, the population of patients that we provide care to, and that collaborative partnership from the teams has been critical. And I sit as one of 3 people in the state through the university who've had the privilege to help all of our centers provide and become at the centers of excellence in our recognition process. And it's been a transition. And we've rebuilt a center or 2 here and there as people come and mentors leave and physicians leave and staff leave. but because I've had the privilege to work for the university, it really does make a difference on how we see and how we take care of our patients. And when we look at, every year we look at those outcomes and those outcome data, and it's all positive. So I know that much of the world has big, beautiful centers for excellence in hospital systems. We have 4 cities in our entire state that have one of those centers. Many of our folks travel long distances, as that we've said, anywhere from 50 to 300 miles to go to a major medical center. So having rural health components that are supported by the big centers and now by 18 smaller centers across our state, because we have champions for the education and champions for care for both diabetes and cardiovascular medicine, has been my privilege, which I get to share today. And I'm always open to talking about how we made it happen and the tools and resources that we use. And I, again, have had the privilege to work in the network at the national level for the last actually 35 years. So I thank you for the opportunity to be here today. I know that, and I'm going to stop sharing. If there are questions, I will gladly take them. And I know that you have my contact information, and I'm always glad to reach out and share the places that we've put and the pieces that we've put together. We're very, very fortunate to have two accreditation boards, both the American Diabetes Association and the Association of Diabetes Care and Education Specialist Centers, that have helped us build, standards and toolkits to help support those rural sites, and they, help us maintain those sites that at least once a year, are, I hate to use the word, but audited. But it's important that we are sure that we maintain best practice. That over the last 5 years, we've looked at the changes and outcomes for an entire population who've improved their health, and we're better able to cope and deal when folks truly have medical challenges. And our bigger centers then can step in and provide that next level of excellence to us. So with that, if anyone has a question, I am more than glad to be available through, chat if somebody has a question, or I know that they have my slides, and I know that they will share them if somebody needs something. Then I thank you for being able to be here today. Any questions? Any thoughts?
Any questions to Dandro?
Any questions? If not, I'll give you back a few minutes of time. I appreciate being able, I'm sorry I missed being able to do it in person yesterday, but I appreciate the opportunity to share.
Thank you, ma'am. Thank you for your participation. You will be getting the participation certificate within 2 to 3 days and a soft copy of booklet and certificate.
I
We
absolutely
truly value
appreciate
your participation and support for the conference. Thank you so much for joining and for your attention.
you guys are always more than welcome. It's my pleasure. And you guys have a great rest of conference. Thank you.
Sorry for the inconvenience. Now, I would like to request Shriman Man NV from MGR University, India, to present on clinically isolated diabetic steatosis.
Am I audible, ma'am? Am
Yes,
I
sir, you
audible?
are audible.
Yes, ma'am. So, hello everyone. I'm Shriman from Panimalar Medical College Hospital and Research Institute, here to present on the topic clinically isolated diabetic steatopathy. Now I will be sharing my screen. So is my screen visible?
Yes, sir, it's visible.
So, thank you, ma'am.
Thank you.
So yeah, this is a case report and case report on clinically isolated diabetic steatopathy. So, what is clinically isolated diabetic steatopathy? First, looking into diabetic steatopathy, it is a rare neurological manifestation of persistent hyperglycemia, primarily observed in poorly managed type 2 diabetes mellitus. It is present as a hyperkinetic movement disorder, which is characterized by acute onset of violent, rapid, and flinging choreoathetoid movements. So, why am I specifically speaking about clinically isolated variant? Traditionally, diabetic steatopathy shows signature hyperdensity on CT or high T1 signal intensity on MRI brain imaging due to gematocytosis in the basal ganglia. So, the evidence for diabetic steatopathy is usually obtained through CT or MRI in a traditional manner, but this has been isolated through only clinical manifestations. In the absence of these radiological findings, the condition is designated as clinically isolated diabetic steatopathy. There are three primary metabolic pathways involved here. One is anaerobic shift, another is the vascular breakdown, and the hormonal role. Now, let's look at a flow chart which explains this very nicely. Asian female with uncontrolled diabetes mellitus has persistent hyperglycemia, which first leads to non oxidative glycolysis in which leads to diabetic steatopathy. There is an anaerobic shift in the neurons where GABA shunt in non-heterotic states, which results in thalamocortical disinhibition. This is the first pathway. Then the hyperviscosity of the blood, which is due to persistent hyperglycemia through the lenticulostriae arteries, causes gematocytosis in the particular regions of the brain. So this is what which results in the T1 hyperintensity intensity in the MRI. And then estrogen levels in postmenopausal women decreases, which causes increased susceptibility to metabolic insult. All these three pathways lead to diabetic steatopathy. Now we look at our case study. A 78-year-old female. She's a known case of type 2 diabetes mellitus for the past 5 years and severe heart failure with reduced ejection fraction of 33% for the 4 years. She developed progressive fever and sudden involuntary movements in the right upper and lower arm. She presented to the OPD with acute breathing difficulty, reduced oral intake, and extreme appetite loss and decreased response. These involuntary movement profiles are consistent with diabetic steatopathy. Now, further analysis is needed for this patient. So, bedside physical examination revealed the anemia status revealed mild general pallor suggestive of acute inflammation or acute on chronic systemic distress. The respiratory rate was notedly increased, which aligns with the primary complaint of shortness of breath. The febrile mild pyrexia or febrile status is consistent with underlying infectious trigger. Systemic examination revealed that systemic examination was found to be normal. And then now we look into our perspective of the case. Here, her HbA1c was on admission was 13.6, which proved severe chronic, poorly controlled hyperglycemia over the past 3 months. Then her renal impairment, serum creatinine was found to be 2.04 milligram per deciliter, which suggests an acute kidney injury triggered by pyelonephritis and dehydration, which was later resolved through the course of the treatment. In many documented cases of diabetic steatopathy, an elderly patient with chronic poor glycemic control is pushed into an acute neurological crisis by concurrent infection, most commonly a UTI or pyelonephritis. The infection unleashes a massive systemic inflammation and oxidative stress. This is actually the acute inflammatory surge, which impairs the regional blood flow to the brain and the blood brain barrier, making the basal ganglia hypersensitive to glucose driven metabolic insult. Her presenting CBG was actually 360, which is way over the limit of 200, which describes the baseline guidelines for diabetic steatopathy. Her serum sodium was found to be 114.5 milliequivalents per liter, on presentation, severe hyponatremia, which progressively improved with the treatment course, with cautious IV fluid and resuscitation. This is highly characteristic of dilutional or spurious hyponatremia caused by severe hyperglycemia. This should actually be distinguished from osmotic demyelination syndrome, which is very significant rule out here. As the glucose levels skyrocketed in the extracellular fluid, it creates an osmotic draw that pulls the intracellular water out into the bloodstream, diluting the serum sodium concentration. The fact that the biochemical markers return to baseline along the rapid resolution of her physical symptoms supports our diagnosis. So this actually was plotted with her course of stay in the inpatient department of general medicine. So you can see that her sugars have significantly dropped below the threshold for the which was also consistent with her symptoms improvement. So this was an axial CT brain showing no basal ganglia changes in the patient. What we usually expect T1 hyperintensity in the basal ganglia region, and which is not seen here. So it can be ruled out. It can be ruled as a clinically isolated case. So specialist opinions were obtained. An abdominal ultrasonography confirmed cholelithiasis and bilateral renal calculi. And a diagnosis of chronic nephrolithiasis and gallstones were also made. Abdominal CT was done, and bilateral acute pyelonephritis and hepatomegaly with cystitis were confirmed. Severe urinary tract sepsis and renal parenchymal inflammation were found to be the trigger for this. Urology consult was obtained where urologists advised a DJ stenting on a later time period. So the treatment and management done for this patient, aggressive glycemic control is the primary intervention here. Initially, aggressive insulin therapy was given with injection human insulin. Therapeutic target restored aerobic glucose metabolism, successively drive the capillary blood glucose down from 360 milligram per deciliter to below the critical value of 200 milligram per deciliter, which is the clinical threshold and which was achieved by day 7. Symptomatic motor suppression. The triple therapy bridge of D2 receptor antagonists, BMAT inhibitors, and benzodiazepine, they provided critical temporary and central neurological stabilization to control and calm the acute violent right-sided choriothetoid movements, while underlying metabolic equilibrium was being restored. Organ protective support was also given since her ejection fraction was very low. Infection control was also done with antibiotics, and as advised by the urologist, the patient was counseled for a DJ stenting on a later stage. The neurometabolic mechanism involved here, which we should predominantly focus on the gamma shunt hypothesis, which states that severe hyperglycemia state switches the cerebral tissue into an anaerobic respiration, where the brain cell use up the inhibitory neurotransmitter GABA via the GABA shunt mechanism. This leads to thalamocortical disinhibition, which triggers the hyperkinetic involuntary choriothetoid movements. As noted in Asian women, these are usually unilateral, also associated with lip smacking movements similar to tardive dyskinesia. The astrocytes versus stroke necrosis. This is also an area which needs to be focused. Unlike the traditional ischemic strokes, where the cells die permanently, in case of diabetic steatopathy, that stems from localized reactive astrocytes, which are also called as gemisocytes, respond to metabolic stress because the pathology is structural, sparring purely cellular. The clinical features are completely reversible once the normal glucose state is restored. So the aggressive insulin therapy was carried out here. Conclusion and takeaways. The diabetic steatopathy is a diagnosis prioritizing physical findings over typical radiological expectations as found in new researches. Complete rapid recovery is possible within days of active glycemic correction below 200 milligram per deciliter. Essential for elderly diabetic patients, particularly Asian women who are postmenopausal and above the age of 50. So these are my references, and thank you for the opportunity.
Any questions to Sriman? Thank you, sir. Thank you for your participation. You will be getting
Thank
the
you.
participation certificate within 2 to 3 days and a soft copy of booklet and certificate.
Thank you, ma'am. Thank you for the opportunity, everyone.
Thank you, sir. Now, I would like to request Tasima Sharif, Wahat Al Shifa Medical Complex, Saudi Arabia, to present on Nutrition Matters Re-establishing Diet as a Core Diabetes Therapy. Now, I would like to request Tasina Sharif, Wahat Al Shifa Medical Complex, Saudi Arabia, to present on Nutrition Matters Re-establishing Diet as a Core Diabetes Therapy.
Hello. 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 Can you hear me? Hello.
Yes, ma'am, you're audible. Kindly go through the presentation.
Can I just forward the presentation with you because I'm having a little bit problem in the screen sharing. Is it okay?
Yes, ma'am. Okay.
Hello. Am I audible?
Yes, ma'am, you're audible.
I have just my presentation can be shared.
Kindly go through your presentation, ma'am.
Hmm? Hello. Hello.
Yes, ma'am, it's visible now.
Okay. I'm Dr. Tasina Sharif, working as a medical director in Wahid Al Shifa. What today we are discussing is nutrition matters, re-establishing diet as a core diabetes therapy. Today's journey, what is the exact problem which we face? Why diabetes management is incomplete without nutrition? When we take food should be taken as a medicine and not as just as choice. The evidence, what we can prove together. Then beyond macronutrients, precision nutrition, and clinical integration. These are the topics which basically I'm going to just slightly touch on. Where is the main problem? The main problem, why glycemic management remains incomplete without addressing nutrition. The main thing which we normally see is the diabetes endemics, a global crisis where diabetes, the rate of the number of patients of diabetes has gone on increasing. And even as we see the pharmacological advances versus the dietary neglect of what we see with our patients, which the on the left which we can see is we have the extraordinary pharmacological progress, the GLP-1 receptor antagonists and the SGL2 inhibitors, which deliver benefits far beyond the glycemic control, including the cardiovascular and the renal protection. Advanced insulin technologies which have been used, and closed loop systems represented by genuine breakthroughs. And then on the right, the same thing. However, we see the dietary counseling remains inconsistently implemented. Suggest studies that fewer than 20% of the people with diabetes receive formal nutritional counseling. Refined carbohydrate intake remains high, and many patients continue to struggle to achieve the glycemic targets. The message is not that the medications are unimportant. Rather, nutrition and pharmacological should be viewed as complementary therapies. We have invested heavily in one, that is mainly on the drugs, while systematically under-investigating the other. Today's objective is mainly to rebalance what we should be managing first. Then food as medicine. Let's now discuss why nutrition deserves to be considered a therapeutic intervention. Food is not simply a source of calories. It influences the hormonal signaling, the inflammation, the metabolism, the gut health, the cardiovascular risk, and the insulin sensitivity. In many respects, food behaves like a biological active therapy. To understand this, let's examine the biological pathway through which the nutrition influences the metabolic system. How the diet modulates metabolic health. Nutrition influences the metabolic health through multiple interconnected pathways, and these effects are measurable as clinical practices. First, the glycemic modulation, then the fiber-rich and low glycemic index foods slow the glucose absorption and the reduce the postprandial fiber exertion. And secondly, the insulin sensitivity, the unsaturated fats and the bioactive components improve the insulin signaling and reduce insulin resistance. Then third, we have the inflammation. That is the processed foods active inflammatory pathways, whereas in the Mediterranean style of food and which have shown to reduce the inflammatory markers such as the CRP and the interleukins. The fourth, the gut microbiomes, the diet the butyrate, which may improve insulin sensitivity and beta cell function. Then we have the oxidative stress, that is the antioxidants. Antioxidant-rich foods may help protect pancreatic and endothelial tissues from oxidative damage. And finally, the cardiovascular risks, replacing saturated fats and monopolyunsaturated fats, improving lipid profiles and reducing atherosclerotic cardiovascular diseases. The main takeaway from this is food is genuinely biologically active. It is not passive background noise. It influences many of the same pathways we target with medications. We have a lot of evidence which also shows the evidence-based theories, that evidence supporting the nutritional therapy comes from randomized control trials, large observation cohort trials, systematic reviews, and metastatic studies. Importantly, the benefits extend more than just the glucose control. Dietary interventions have been shown to improve the body weight, the blood pressure, the lipid profiles, inflammatory markers, and the cardiovascular outcomes. The breadth of the evidence is one reason why the organizations such as the ADA and the EASD consider medically nutritional therapy a cornerstone of diabetic management. Now we have what to eat. The evidence-based thing which we have, that is which increases the evidence-based components, specific nutrients and foods which constitute evidence in diabetes management. What we should increase is the dietary fibers, then the minimal use of the whole processed food, unsaturated fats, and non-starchy vegetables. Then to reduce the refined carbohydrates, ultra-processed foods, saturated fats, and the added sugars. We know about the Mediterranean diet. What we have already read and what we have seen. The landmark is the premix trial enrolled around 7,400 individuals as a high cardiovascular risk and demonstrated approximately a 30% reduction in major cardiological events. The findings is particularly relevant because the cardiovascular diseases remain the leading cause of mortality among people with type 2 diabetes. The meta-analysis has also shown the HbA1c reduction of approximately around 0.9%, along with improvement in the weight, the lipid profiles, and the inflammatory markers. Now, when we are coming that is beyond macronutrients, traditionally, discussion about nutrition has focused on carbohydrates, fats, and proteins. However, emerging researchers suggest that the framework may be incomplete. Two concepts are increasingly important. That is mainly the food structure and the meal timing. These concepts help explain why food with similar nutrients profile can produce very different metabolic responses. They also remind us that nutrition is not only about what we eat, but also how and when we eat it. Let's begin with food structure. The physical architecture of the food influences the digestion, the absorption, and the metabolic responses. For example, whole almonds and almond flour contain similar nutrients, yet produce different glycemic responses because intact cell wall slow digestion. Similarly, a whole apple produces a very different metabolic response compared with apple juice. Processing disrupts the natural process matrix and accelerates the nutrient absorption. The second concept is the circadian biology. Human metabolism follows a daily rhythm. Insulin sensitivity tends to be higher earlier in the day and lower in the evening. Studies demonstrate that the same meal consumed in the morning often produces a lower glucose response than we consumed at night. Time-restricted eating strategies have also shown improved in the glycemic control and body weight in some studies. The clinical message is just straightforward. We should be advising patients not only on what to eat, but also on when to eat. Precision nutrition. One of the most exciting developments in the modern nutrition science is the precision nutrition. For decades, dietary recommendations have largely been developed at the population level, yet we increasingly recognize the individual respond differently to the same food. Precision nutrition seeks to personalize dietary recommendation using clinical characteristics, behavioral factors, metabolic data, and increasingly continuous glucose monitoring. The goal is not to replace the general dietary guidance. The goal is to make the guidance more individualized and more effective. Now, when we come to the individual glycemic responses, the concept is highlighted by landmark study from the Wisman Institute publications in the Cell. Researchers have monitored approximately around 800 participants using continuous glucose monitoring while assessing response to standardized meal. The findings were striking. Individuals demonstrated dramatically different glucose responses to identical foods. A food that produced minimal glycemic impact in one person caused a substantial glucose spike in the other. The study suggests that factors, including the gut microbe, contributing significantly to the viability, although microbe science remains an evolving field. These findings highlight an important principle. Identical dietary advice may not produce identical outcome. As clinicians, this reminds us that that personalization of each patient is very important. A practical precision nutrition framework, however, we can apply these concepts in practice. The first step is the clinical assessment of the patient. This includes the HbA1c, the weight, the lipid profile, the renal function, the cardiovascular risk factors, the medications, and comorbidities. The second step is understanding the behavioral and the social factors. Recommendations must be realistic, culturally appropriate, and financially feasible. The third step involves the metabolic tools such as CGM, where available. Even a short period of CGM use can provide variable insights into individual food responses. Finally, all the information is integrated in the personalized nutritional plan that is reviewed and adjusted over time. Importantly, nutrition and pharmacotherapy should not be reviewed as competing strategies. The greatest benefits are often achieved when both are optimized together. Now, the clinical integration, that is, at this point, we reviewed the science. The next challenge is implementing, that is, how do we move from evidence to action? How do we incorporate nutrition into busy clinical environments where time and resources are limited? Ultimately, evidence improves outcome only when it is translated into everyday practice. The barriers to implements. Several barriers contribute to limit the integration of nutrition into diabetes care. The first is time. Most consultations are very brief, making comprehensive dietary counseling difficult. The second is the training. Many healthcare professionals receive relatively limited formal nutritional education. The third is the infrastructure. Access to dietitians, reimbursement modules, and referral pathways very considerable. And finally, the patient-level factors such as affordability, the food environment, the cultural preferences, and the health literacy, and all the influences which are there around the patient. Recognizing these barriers is essential because effective solutions must address each level simultaneously. the practical solutions. Now, what we can do, the encouraging news is the meaningful change does not require a complete redesign of the clinical practice. Simple actions can be made to substantiate differences. One practical strategy is to ask 3 questions. That is, what are the main carbohydrate sources? How many meals does a patient normally take? Do you regularly eat after 8 p.m.? These questions often reveal important opportunities for intervention within minutes. The plate method is also very useful to provide the patient a very simple visual framework. We should also document dietary patterns as routinely, as well as documented along with the HbA1c, the blood pressure, and the weight. We get measured measure tents to receive. That is, these are the small ways where we can just assess the patient to understand what the patient is actually doing wrong. The basic key takeaways which we have is, as we approach first, the nutrition therapy works and can produce clinical meaningful improvement in the glycemic control. Second, the Mediterranean diet remains one of the most evidence-supported dietary patterns for diabetes management. Third, the food structure and meal timing influence metabolic responses and deserve greater attention. Fourth, precision nutrition represents an important further direction in diabetes care. Then nutrition and pharmacologicals are synergist therapies, not competitive ones. And finally, meaningful integration of nutrition into clinical practice is very achievable starting from today. Now, in conclusion, I would like to say for centuries, clinicians have recognized the relationship between food and health. What has changed in the strength of evidence supporting their relationship? Today, we understand that nutrition influences glycemic control, insulin sensitivity, inflammation, the cardiovascular risks, and overall metabolic health. The challenge before us is not a lack of evidence. The challenge is implementation. As diabetes care becomes increasingly sophisticated through medication and technology, nutrition must retain its place as a center of therapy. Our patients deserve both the best pharmacological and the best nutritional care delivered with the same precision, follow-up, and accountability. Thank you very much. I'm really thankful for being allowed, because was not able to come personally, but I mean, like, it was a really enjoyable thing to join this session. Thank you so much. And if there's any questions, you can ask me. Hello?
Any questions? Thank you, ma'am. Thank you for your participation. You will be getting the participation certificate within 2 to 3 days and a soft copy of booklet.
Thank you.
Now, I would like to request Richard Hendricks from clinical pharmacist and independent prescriber, St. Wilston Surgery, Southern Berkshire, UK, to present on improving 9 key care process completing in early onset type 2 diabetes.
Hello. I hope I'm audible.
Yes, sir. Kindly go through the presentation.
Yeah, thank you. Thank you. I hope my screen is visible.
Yes, sir, it's visible.
Yeah. Thank you for providing me this opportunity. So, yeah. Hello there. My name is Richard Hendricks, and I'm from the Wolfstand Surgery, Southern Berkshire, UK. So I think, like, a really good morning to everyone. So yeah, the time now is around 11 in UK. So yeah, let me proceed now. So my topic is improving 9 key care process completion in early onset of type 2 diabetes. So the major problem which we face these days is the not like being able to identify the diabetes early on. Because if we can like try to recognize it early, we will be able to cure the patient in a better and much. So, so that's why this is my topic, and I'll be going forward on this one. So, the age at mostly whatever the diabetes patient which will be diagnosed under the age of 40. So we try what I'm trying to convey here is we should be able to uh, recognize the type 2 diabetes in early age so that it will be better, it will be better to cure after we once recognize that. So early onset type 2 diabetes T2DM, I hope everyone is aware of that, defined as diagnosis under the age of 40. It is currently rising rapidly in the UK and globally. So I couldn't speak for globally, but I'm pretty sure it is very much rising in the UK. The phenotype carries a more aggressive disease course with significantly higher lifetime cardiovascular and rental risk compared to the later onset T2DM. So with this, the risk of getting cardiovascular disease is very high. So it is very much important to recognize this early onset of the age before we get diagnosed, so that we will be able to decrease the risk of cardiovascular diseases. So national audit data reveals that only 37% of patients under 40 achieve all the nine nice key care processes. So within the 12 months of diagnosis, so this is very much below the national benchmark. So we should be able to if we are able to cure it before before the age of 40, then that's a good mark. But at present rate, it is just 37%. So which is not a good amount of people getting cured. And this type 2 diabetes has been rising very exponentially. So this process include the 9 processes which I have been speaking about. This include the HbA1c, BMI, blood pressure, cholesterol, urinacia, food exam, retinal screening, smoking status, and education referral. So with this, taking this into consideration, I would like to proceed further. So to improve the line, so these are the this aim and the methods which I suggest, so that this can be used to cure the diseases early onset before 40. So to improve 9 KCP completion rates in a UK primary care setting through targeted audit-driven interventions, bringing practice performance in line with national NICE standards. So the major aim is here to increase this percentage. Whatever which we are seeing right now is the current benchmark in the nation. And with that keeping in mind, so we would like to increase that as much as possible so that we can like reduce the risk of cardiovascular diseases. So in the retrospective audit, I would like to say that 10 patients diagnosed with early onset T2DM, less than 40 years, I have reviewed across all the 9 nice key parameters. So which all these key these key parameters which I have told. So there's 10 patients out of which sorry, yeah. So 10 patients diagnosed with reviewed across all 9 key. So what I'm telling is we have a very much less rate of people getting diagnosed before the 40, so that we need to reduce the risk of that cardiovascular diseases and the automated IT reminders. So the another one approach which was very interesting is we should be able to getting ourselves checked up, or the patients which who are more prone to getting T2DM, get them checked up every quarter, not only quarter. We can take a quarter into consideration, or maybe we can go with around half yearly or yearly. That's as well fine. So once we go through all these 9 key parameters, then it's very high chance that we will be able to identify the T2DM before 40. So in that way, we will be able to treat the patient in a better way, so that he won't be having he won't be prone to any other scenarios in his life, like other diseases in his life. So also, like if they are able to take more time and have a better appointments with their doctors, that would also be helpful. And also, like there should be a specific T2day program so that it would be helpful, like it would be helping the patient in order to like to understand himself. Yeah. So these are a few metrics which like I have gone through and I have collected them. So 100% HB1AC and BP completion achieved, and 80% like we get to know around urination and food exam. So the average 9 KCP completion rate at the age of 37 is just after like just around 89%. And these are like majorly facts and stats which I have compiled and like put them into a graphical way. So this is a very high chance that like before, even if the patient gets the T2DM and if he's not able to identify himself, if we go through the 9 keys KCP parameters which I have suggested in previously in the slide, that would be useful for the patient in order to treat him well. So so these are the my key findings which I have presented here. So whoever like the BMI is greater than 30, they are like considered as obese, as we all know this. And people under the BMI of 25 to 30 are considered overweight. And diabetes majorly comes with a high risk of obesity due to the sugars which we consume and all the other dairy items which consume every day. So, like there's a high obesity burden, and there are few monitoring gaps. Like this is the major issue, because you see, we are not able to like at least go through the one of the 9 KCPs which I have mentioned, so that it will be very much helpful to identify the diabetes early on stage. So, yeah. So these are my key findings which are presented here, and yeah. So, like at last, my conclusion is that we should be able to keep up a low cost intervention. So whatever we are trying to like provide with the 9 KCP parameters which I'm trying to say, if we keep them at a lower cost, then every patient it would be more affordable and they would be able to get them like diagnosed every 3 months, 6 months, 12 months, which I have mentioned. Because there's with growing age, there's a high risk of the type 2 diabetes. So it's highly recommended that patients get checked themselves at their like regular intervals. So it might be quarterly, half yearly, semi-yearly, annually, whatever they prefer. And also the consultant should be more like they should be in more touch with them, because once they get connected with the patient, they get to know better about them. So that will be a very good reason, so that they will be able to understand the patient better, and we will be able to recognize as many people with diabetes for 40 and we can cure them. So this will be able to reduce the cardiovascular diseases which is a high risk after they get diagnosed after 40. That's all more from mine. Thank you everyone for giving me this opportunity.
Any questions? Any questions to Richard? Thank you, sir. Thank you for your participation.
Thank you everyone for being such a good listeners.
You will be getting the participation certificate within 2 to 3 days and a soft copy of booklet. Now, I would like to invite William Harrington to present on adjunctive tirpitin in type 1 diabetes with severe obesity and insulin resistance, a case demonstrating marked improvement in glycemic control.
Hello, thank you for giving opportunity. Metobegin, adjunctive tirzepatide in type 1 diabetes with severe obesity and insulin resistance, a case demonstrating marked improvement in glycemic control. Patient background: long-standing type 1 diabetes mellitus accompanied by severe metabolic complications and persistent therapy resistance. High-risk patient case profile. Primary demographics: clinical history 21-year history of insulin-dependent type 1 diabetes mellitus with severe baseline insulin resistance. Obesity profile: BMI of 40 kg/, signifying class 3 morbid obesity. And their complications: bilateral character neuropathy, severe peripheral neuropathy, and recurrent food ulceration causing significant mobility restriction. And the baseline metrics, you can see here, time range 36%, and after that hyperglycemia is going up 62%, is very high. Hypoglycemia will be little bit 2%. Mean glucose 11.6 mmol. But you can see the difference glycemic variability. It's approximately 37, almost 38%. The patient exhibited profound persistent hyperglycemia 62% of the day, with dangerous glycemic fluctuations despite optimized intensive insulin therapy. And meanwhile, the treatment strategy: designing a customized off-label therapeutic model using multi-receptor incretin coagonism to tackle cellular insulin resistance. You can see here, multi-step therapeutical protocol. Metformin titration: metformin was introduced and steadily escalated to 1 gram twice daily to help sensitize hepatic and peripheral tissue pathways. And tirzepatide weekly, initiated at 2.5 mg weekly and safely titrated up to 5 mg weekly. We established dual GIP and GLP-1 receptor agonists and insulin adjustment. Empirical insulin dose reductions of 10% to 50% alongside shifts to postprandial dosing and intensive ketone safety checks. And following the addition of tirzepatide, and the patient experienced significant improvement in glycemic blood glucose control, reduction in HbA1c levels, meaningful weight loss, decreased daily insulin requirements, and improved overall metabolic health. And the clinical outcomes, reviewing the dramatic improvements in continuous glucose monitoring metrics and glycemic stability and total insulin requirements. And you can see here comparative glycemic metrics. After 4 months of weekly injective tirzepatide treatment, time in range increased from 36% to 69%, while overall hyperglycemia fell dramatically from 62% to 25%. Metabolic and insulin burden impact. Glycemic optimization. Glucose control. Glucose control levels dropped significantly from 11.6 to 8.1. GMI improvement. GMI lowered to 6.8 from a high of 8.3. Stabilized variability. Achieved sustained glycemic profile control with zero severe hyperglycemic events. Sparing insulin burden. 50% dose reduction slash total baseline daily insulin requirement by approximately half. Basal and burst shifts. Substantial therapeutic reductions across both basal infusions and bolus injections. metabolic efficiency, noticeably enhanced patient compliance and systematic sensitivity. Safety protocols and considerations, careful patient selection. Incretin coagulation in T1D should only be considered for patients with confirmed severe clinical obesity and profound insulin resistance. Mandatory insulin titration. Proactive upfront reduction in insulin dose 10 to 50% is vital to prevent clinical hyperglycemia upon starting tirzepatide. Frequent ketone tracking. Standardizing frequent home ketone monitoring helps maintain clinical safety and ensures early diabetic ketoacidosis detection. Atypical euglycemic decay. Clinicians must maintain clinical suspension of for atypical euroglycemic decay presentations where glucose levels look normal. And the key milestones and takeaways. Milestone 1. And baseline profiling severe obesity and erratic glucose control despite optimized insulin therapy. And milestone 2. Therapeutic initiation strategic addition of metformin and weekly tirzepatide with proactive insulin titrations. Milestone 3. Metabolic success. Time in range near double to 69% alongside a 50% drop in overall insulin requirements. And the milestone 4. Clinical verdict. Larger, robust clinical studies are needed to evaluate long-term of labeled safety profiles. And my dear colleagues, thank you for listening to me and giving me this wonderful opportunity. Thank you.
Any questions? Thank you, sir. Thank you for your participation. You will be getting the participation certificate within 2 to 3 days and a soft copy of booklet.
Thank you.
Now I would request Emily Carte to present on lived experiences of family caregivers.
Good morning, everyone. Today I am presenting a study titled Living Experiences of Family Caregivers for Senior Citizens Who Are Suffering with Diabetes. The study explains the challenges, experiences, and coping strategies of family members for the elderly diabetic patients. Next, uh, diabetes is a chronic condition that requires continuous monitoring, medication, and dietary management. In many communities, family members become the prime caregivers, carrying significant physical, emotional, and financial responsibilities. The study aims understanding the daily realities of family caregivers, identifying physical, emotional, and financial challenges, exploring coping mechanisms and self-care strategies, provide information that helps improve healthcare and support management, support programs, methodology. Like this research used a quantitative psychological approach. 5 family caregivers were selected through a purposive sampling, and the data were collected through semi structured interviews. The responses were analyzed using thematic analysis to identify common experiences and themes. Next, the key findings, challenges. The study found two major suspects of caregiving. Challenges. Continuous caregiving causes physical exhaustion and mental stress. Caregivers often have limited time for themselves. They may experience social isolation and burnout. And the major second part is positive experiences. Caregivers feel satisfaction when they see their elders, relatives comfortable and healthy. Family, love, support, gratitude, and responsible even motivate them. Many caregivers develop resilience and confidence through their experiences. Next, coping strategies and finding meaningful fulfillment. Uh, like caregivers manages through positive thinking, acceptance, faith, and spiritual support, sharing responsibilities with the family members either, seeking advices, support from their communities. Mm, like uh, in conclusion, caregivers for diabetic elderly family members in both challenging and meaningful. The study recommends caregivers training programs, mental health support services, and community respect. Programs that reduce caregivers' burden and improve quality of care. And thank you for the opportunity. Thank you for listening. I would be happy to answer any questions. Any queries?
Any questions to Emily? Thank you, ma'am. Thank you for your participation. You will be getting the participation certificate within 2 to 3 days and a soft copy of booklet. Thank you very much to all the participants, those who joined the webinar on Nursing and Diabetes Conference during this period having different time zones. Our most sincere thanks to all the speakers, students, delegates, journal collaborators, media partners who have joined from different destinations around the globe for their support and cooperation. Let us thank speakers who have responded so well to our invitation to participate in the conference. We have revised and received several papers which will form from the basis of our discussion in the various sessions. Let us thank all the participants and associations with the conference by your presence. A special thanks to Program Manager Maunusha his for her continuous effort in putting us all together under one platform in this online event. I would also like to thank participants. Hope we can collaborate in future events in virtual or physical events. E-certificate e-handbook will be sent through email within 2 to 3 days after the completion of the conference. Finally, we extend our appreciation to each of you for your participation in the online conference. Thanks again. Have a nice day. This is Maheshwari signing off.